Welcome to the Thyroid Stimulating Podcast. This podcast was created in partnership with the American Thyroid Association to discuss up-to-date diagnosis and management of a wide array of thyroid diseases. I'm your host, Dr. Kaniksha Desai, and today we're talking about a condition that's frequently under-recognized in clinical practice, postpartum thyroiditis. This autoimmune thyroid disorder affects up to 5 to 10% of women in the first year after giving birth. It typically starts with a phase of hyperthyroidism, which may be mistaken for the normal demands of the postpartum period. This is then followed by hypothyroidism, which can significantly impact energy, mood, and recovery. While most women eventually return to normal thyroid function, some develop permanent hypothyroidism. In today's episode, we'll cover the typical timeline and phases of postpartum thyroiditis, risk factors and diagnostic workup, management strategies, including when to treat and when to monitor, and how to counsel patients navigating this condition. Joining us today is Dr. Carolyn Nguyen, Clinical Associate Professor at the Keck School of Medicine of USC. Her clinical research expertise is in the diagnosis and management of thyroid disorders during pregnancy. Her work spans hyperthyroidism, hypothyroidism, and thyroid cancer, as well as postpartum thyroiditis. She is published in leading journals, including Thyroid and JCNM, and Dr. Nguyen is also a member of the writing group for the upcoming Thyroid and Pregnancy Guidelines, expected later this year. Thank you for joining us today. We're excited to have you talk about postpartum thyroiditis.
Thank you, Dr. Desai, for having me.
So let's start. For our listeners, can you briefly define postpartum thyroiditis?
Originally, it was described as the occurrence of de novo transient thyroid dysfunction in the first year of pregnancy in a previously euthyroid person. That was the original diagnosis. However, this definition is a bit limited, and now we think of it slightly differently. We think of it as a pattern of transient autoimmune thyroid dysfunction that basically occurs within the 12 months after delivery. Essentially, it's a form of silent thyroiditis, silent in that it's not typically associated with pain. So it involves a form of kind of chronic lymphocytic infiltration and tissue injury, leading to essentially a release of large amounts of thyroid hormone into the circulation, as you mentioned. And what's unique about it is that it occurs in the postpartum period. And why that may be, the hypothesis is that during pregnancy, there is suppression of the immune system, and it's most prominent in the third trimester. This is why many autoimmune conditions improve in pregnancy, such as Graves' disease. Often, patients can come off of their antithyroid drugs in the third trimester. So what happens is that as pregnancy progresses, the immune system is suppressed, and then postpartum, the immune system rebounds. And this is when autoimmune conditions may present. So interestingly, we see postpartum thyroiditis occur earlier in the postpartum period. We think because it's associated with cellular immunity, while conditions like Graves' disease tend to occur later in the postpartum period, and the hypothesis because it's associated with humoral immunity and antibody formation.
Okay, thank you. So that kind of helps us. So this is different than the Graves. I just want to clarify. This is different than the Graves recurrence for those of us, those people who are listening. So when do you suspect this versus like Graves' disease or Hashimoto's?
Yes, so typically you can tell sort of by timeline a little bit in the postpartum period. So generally, postpartum thyroiditis tends to happen a little bit earlier. Occurrence tends to happen usually within the 1 to 6 months. You should have presentation of symptoms typically, whereas Graves tends to be in the latter part of the postpartum period, maybe after 6 months to 12 months. But those are just general guidelines, and there's definitely going to be overlap in the middle. So you bring up a really good point that it can be challenging to tell the difference between the two because they both can present with hyperthyroid symptoms and hyperthyroid labs. A few things can help. Sometimes the clinical exam, like in Graves' disease, if you have eye disease or if you have a goiter, then that would be more suggestive of Graves' disease. You could also do laboratory testing if clinically you couldn't tell. Laboratory testing would be the thyroid function test, so TSH, T4, plus or minus T3 could help. Between the two, to what would help you the most to distinguish, because you could have overt hyperthyroidism in both, would be the antibodies. So usually the TRAB or the TSH receptor antibodies, or thyroid stimulating immunoglobulin, TSI. And those are the antibodies that are responsible for Graves' disease, and the pathophysiology of Graves' disease. So if you have those present, then you should suspect that this is Graves' disease more so than just postpartum thyroiditis.
Is there any imaging that might help, like a thyroid ultrasound?
We don't routinely order thyroid ultrasounds in the evaluation of this. So usually you would have your clinical suspicion, then you would do your biochemical testing. The ultrasound, if you had it, if you happen to have it already, it could be helpful in the sense that typically with a thyroiditis, you would see more of a heterogeneous ectotexture on the thyroid, maybe areas of hypoechogenicity. The thyroid gland itself could be normal in size or maybe slightly enlarged. And then the vascularity might be the most helpful in the sense that usually it would be reduced in thyroiditis in contrast to Graves' disease, which would show kind of increased vascularity. In your clinic or already had one coming in, that could be helpful. But I would say also the antibody testing tends maybe to be easier.
And in non-pregnant women, we also use a thyroid uptake and scan. Can you talk a little bit about that? Why
Mhm.
it wouldn't work here or would work here?
Typically, postpartum, we tend to try to avoid things like that because most of the time patients might be breastfeeding, and it's also a bit of a cumbersome study, and it takes time, and also isn't really necessary in the sense like we have so many other options that are so much easier. So I think that's why it's kind of fallen from use.
Okay, thank you. So that's how we work it up. It's a
Mhm.
biochemical plus clinical evaluation. We briefly talked about this, that it starts with the hyperthyroidism and then it goes through hypothyroidism and then comes out the other end normal in a lot of people. But can you walk us through what
Mhm.
a typical clinical course looks like?
So, patients often follow up in postpartum. It's common to have like a 6-week follow up with their OBs, and they might present with symptoms. These can, in the hyperthyroid phase, it can present with symptoms like palpitations, maybe irritability, increased anxiety, heat intolerance, maybe a little bit of like a tremor. Um, or they might find they notice differences in their ability to breastfeed, and milk production can be altered. Um, so those symptoms can sometimes bring patients in initially. However, it's important to note that some patients might have those symptoms and never notice them, and they may kind of just exit out of the hyper phase and present in the hypo phase. So in the hypo phase, the symptoms are completely the opposite. You're going to have more of like this fatigue, maybe cold intolerance, constipation, um, difficulty concentrating, impaired memory, dry skin, um, the classic symptoms of hypothyroidism. So the symptoms are challenging because they can vary significantly depending when the patient presents. And then also what makes it challenging in the postpartum is that many of these symptoms overlap with just being in a postpartum period and having sleep deprivation and a new baby to care for. So I feel like it can be really hard just to base this on symptoms alone, but I do think it's really important for the clinician to ask patients about these symptoms, because what happens is that a lot of patients will just attribute any symptoms they develop in the postpartum period to being postpartum, and they just think it's normal. So I think clinicians need to make a better point of asking and seeing, is there more to it than just postpartum?
And would there be any harm
Um,
in just over like testing, like just getting that TSH test and
everybody?
screening everybody? Or, because, it's kind of hard to see which of these symptoms are postpartum versus which of them are
I know.
truly
Yeah,
symptomatic, especially unless it's an extreme, right?
yeah. Well, that raises a bigger question, this idea of universal thyroid screening or not. But you bring up a good point because, the estimated prevalence of postpartum thyroiditis, like you said, it's like 8%, 5 to 10%. That's 1 in 12 persons are going to have postpartum thyroid dysfunction. And that's only estimated based on observational studies on clinically apparent disease. meaning that we're probably missing a lot of patients who never present because never talk about their symptoms, never mention them. That's a bigger topic about whether we should really be screening everyone, but definitely I think asking questions and screening for those symptoms and then testing patients who are reporting these symptoms makes a lot of sense. One thing I kind of want to bring up about the testing too that can sometimes be confusing is that, so we test with TSH often, and many people will order like a TSH with reflux, free T4. However, in this period, the postpartum period, it can be a little bit tricky because, well, maybe you could still order it and you could get it correctly, but it is important to look at both the TSH and the T4. So if your lab doesn't, some labs, interesting, don't reflex if the TSH is low. They only reflex if the TSH is high. So in this scenario, you may want to order both because in that transition phase from hyper to hypo, you could have a TSH that lags behind that will look hyper, right? Be low. But when you actually get the T4 levels, they're low because they've already transitioned into the hypo phase. The TSH is lagging behind and hasn't kind of caught up. So I think in this scenario, looking at both can be helpful to know exactly where are they in the course of the postpartum.
So just to clarify, you have initially the free T4 goes up and then the TSH comes down, right? And then the
Uh-huh.
free T4 will come down and then the TSH will go up. Then both of them will hopefully be normal.
Yes, correct. So when you talk about the overall prognosis, generally the thought is that it'll last about 1 year, which is a long time, right? So these patients do need to be followed because they're going to go through these transitions. And when you start with hyper, and monitoring for hyper and treating conservatively for hyper, then they switch to the hypo, they should be offered treatment in the hypothyroid phase if they're symptomatic and want it, because it can be quite significant. Most of the time, these TSH levels, they can be double digits and really high because these patients are young. So offering treatment during that time would be important for symptom relief. And then you bring up a good point that at 12 months, this process tends to resolve. And so it would be important at the 12-month period to assess for whether patients need to continue on medication or if they can be titrated off the medication. And many will be able to come off the medication at 12 months, but there are a portion of patients, the prevalence is quite wide, anywhere from like 5 to 20%, who may end up having to stay on thyroid hormone medication even after that 1 year postpartum.
That's a lot of information. So I kind of wanted to break it down into little pieces. We talked a lot about the hypothyroidism phase, but if we could go back to the hyperthyroidism in the beginning, is there
Mhm.
anything we need to do for treatment for that phase?
So you can offer patients beta blockers to help with the symptoms, just like we would in any kind of hyperthyroid condition. The beta blockers can help significantly with the palpitations, the tremors, the heat intolerance. And usually in postpartum, we prefer propranolol or metoprolol. Propranolol is nice. It's dosed about every 8 hours. So patients can take it almost on an as needed basis. And so I find that a lot of patients like that because sometimes the symptoms are more prominent at certain times of the day. If not, you can take like metoprolol, which is longer acting. We tend to avoid atenolol just because there seems to be increased transfer into breast milk. It is felt to be safe to use beta blockers for short periods of time in the lowest effective dose in the postpartum period. And it can really help with symptoms. Even during lactation, it is acceptable. And usually we use it really only for like a few weeks, I find is what most patients need.
And then just to clarify, the symptoms that it's controlling are the heart racing. What other symptoms?
Maybe if they have a little bit of a tremor, the palpitations, kind of that increasing feelings of anxiety tends to kind of be people commonly complain about. You can also present with this heat intolerance that people can feel. So if you use like a non-selective beta blocker such as propranolol, it can kind of help with all of those.
And this will expedite the hyperthyroidism phase or does nothing to the hyperthyroidism?
No, it's just symptom control. So some patients who feel like the symptoms are mild but tolerable, they don't always opt to use beta blockers. But it's really just for the patient who's really having a hard time, I think, with the symptoms. I would find that part, like I said, many patients maybe don't even notice in that early postpartum period, they have so much else going on, but it can be helpful for certain patients. I think the
And
treatment for the hypo is a little
more.
bit more significant. Yeah.
And just to
Mhm.
clarify for everybody, antithyroid drugs are not indicated here.
That is correct. So, because of the pathophysiology of the condition, antithyroid drugs wouldn't help because the issue is not about the overproduction of thyroid hormone, it's the release of preformed thyroid hormone already. So, we definitely wouldn't want to treat with antithyroid drugs, especially in an exposed mom and baby to it if not necessary.
Okay, and then for the hypothyroid phase, we talked about starting on thyroid hormone, and we're talking about levothyroxine for everyone who's listening here. You
Mhm.
kind of briefly touched on the topic, but is there a TSH that you think people should be started on, or it's just symptom control?
I think it's symptoms, but also maybe biochemical too, because even outside of pregnancy, we will start patients, with TSH is greater than 10. We tend to recommend treatment for that. So I think in this scenario, it could be the same, if not even a lower threshold to start treatment, right? Because if patients are already symptomatic and their TSH, is elevated and they're going through this process, it would make sense to kind of support them with some thyroid hormone support. And usually it will present as like an overt hypothyroidism. So then we typically will say you can replace with full dose replacement for overt hypothyroidism. And overt meaning both the TSH and the T4 are going to be abnormal. So that's 1.6 micrograms per kilogram per day, as we would in a non pregnant patient.
So for mild subclinical hypothyroidism, you would consider like 50 micrograms, and then for overt, the full dose.
Yeah, so if it's mild, you could definitely start on a lower dose and then watch and monitor the patient and see if it needs to be titrated up. Mhm.
Which brings me to my next question. Actually, how frequently should you order labs then?
So typically, like in the beginning, when you first see the patient and you've made the diagnosis, right, and it's hyper, it's going to be a transient process and it's going to resolve, and nothing about your treatment is going to be adjusted necessarily by the lab. So, in that part, I don't think you'd have to test too frequently, but perhaps maybe within like 4 to 6 weeks later, because what you're looking for is when they start to transition into the hypothyroid phase. And that's a little bit tougher to predict depending when they present to you. So that's what you're watching out for. And then when that starts to happen, again, you would tell them to stop the beta blocker because they don't need it anymore at that point. Then consider adding on the thyroid hormone if they would like to start treatment. If they're not and they want to kind of monitor and wait, because sometimes it takes a while for that T4 to kind of go become low, right? So once they can kind of keep monitoring maybe every 4 to 6 weeks. And then eventually, once you're in the hypothyroid phase and you've decided to treat them, then you're going to just monitor kind of every 6 weeks as you would in a non-pregnant patient that you're treating with thyroid hormone, until you can optimize the thyroid hormone levels with the right dose.
And then when do you
And then,
recommend titrating off the thyroid hormone? Because you did said a lot of these patients, like the majority
yeah,
of them, recover, right?
yes. So at 12 months is when I start to think about bringing down the dose. If they're doing well, at that point, I kind of just start to titrate down on the dose gradually. And again, repeating labs like every 6 weeks to see how they tolerate that titration.
And then the people who are permanently hypothyroid, you just leave on levo, and when you titrate down, their
Yes,
TSH increases, and so you have to leave them on levothyroxine. For everyone
yes,
who recovers, does this ever happen again with future pregnancies?
yes. That's actually one of the biggest risk factors is if somebody has had this happen in one pregnancy, there's a risk of about 70% that they're going to have it in a future pregnancy. So that's really important to tell the patient and prepare them. It's also important that, most of the patients who have postpartum thyroiditis, the other big risk factor is thyroid autoimmunity. So if you already know you have TPO antibody positivity, less so a TG antibody positivity, or findings on ultrasound that point towards thyroid autoimmunity, these are the risk factors, right, for potentially having postpartum thyroiditis, and also the risk factors for having hypothyroidism. So it can be helpful information as well for kind of predicting who might be at risk going into a future pregnancy and who might be at risk for kind of permanent hypothyroidism. Even those who recover and become euthyroid 1 year. Potentially 10 to 50% of them long term may still develop permanent hypothyroidism. So, kind of have to keep watching these patients and also preparing them for future pregnancy. Because sometimes patients become hypothyroid in that phase, and if they're not aware of it, and they go into a second or a next pregnancy, then they could be hypothyroid preconception. And they should check their thyroid function before the next pregnancy in the event that they did have more permanent hypothyroidism resulted.
And are they any other risk factors like age or family history or other medical conditions we should be concerned about?
Probably the best data is for other autoimmune conditions um, in the person themselves or family history of autoimmune conditions. So that would be the kind of other risk factors I would consider.
So this would include like type 1 diabetes, lupus, things like.
Yes, yes.
And
Mhm.
then, so all of these patients see endocrinology. I know we're kind of limited endocrinologists out there, but how do you feel about them seeing endocrinology, or when do they need to see endocrinology?
It's interesting because probably most of these patients never see endocrinology because these are patients who didn't know they had thyroid disease or a thyroid condition. And so more likely they're going to be followed up by their OBs at the postpartum visits, or maybe their general or primary clinician. So I think everybody who cares for patients in pregnancy or around pregnancy needs to be aware of this diagnosis and ideally become comfortable with kind of diagnosing it and treating it. I think patients that should see endocrinology are those who perhaps if the clinician's not sure about the diagnosis, right? Like they're not sure if it's postpartum thyroiditis or maybe it's Graves or maybe it's hyperthyroidism from some other etiology, then they should be referred to endocrinology. Um, or if the clinician just doesn't feel comfortable, managing postpartum thyroiditis, they should then refer to endocrinology because these patients do need to be followed for that entire year and where a lot of change can happen during that year. And then even after that year, when you're titrating down on the dose. But I think if OBs or primary clinicians became more familiar and comfortable, they could manage this. And probably with its high prevalence, it would be necessary to really treat all the patients out there.
Well, thank you so much for all of the non endocrinologists managing this. What are your three takeaways?
So again, the first would be to really be aware of the high prevalence of postpartum thyroiditis, and also just the increase in thyroid dysfunction that can happen postpartum, and ask patients about it because they may not volunteer the information or even be aware of it. So I think asking about it is step one. Then, if you make the diagnosis, offering symptomatic treatment is step two. I think, and there was kind of this thought of this is a transient process, it will resolve on its own, it doesn't need to be treated. I think for a patient to have abnormal thyroid function for a year during a time that is extremely stressful already and hard, such as the postpartum year, is kind of a disservice to patients. So I think they need to be informed that there are treatment options to help them feel better, not that this is just going to resolve on their own and that they need to kind of just get through it. So that's number two. Three, counseling on contraception until a patient is euthyroid would be very important. And then planning future pregnancies for the reasons we discussed, and then monitoring these patients for long-term hypothyroidism.
Thank you for joining us today and talking about this condition that's, we often overlook it. And it's a pretty important condition occurring at a very vulnerable time for a lot of people. So thank you for joining us, Dr. Wen, today. And please stay tuned for next month's episode of the Thyroid Stimulating Podcast.